Our fifth manuscript, the effect of using a machine learning-derived algorithm versus standard care on intraoperative hypotension during elective non-cardiac surgery, or the HYPE randomized clinical trial, will also be released in JAMA by Dr. Wijnberge.
Thank you for the introduction, and I would like to thank JAMA and the Society of Critical Care Medicine for the honor to present our results here today. My name is Marije Wijnberge. I'm an MD from the Amsterdam University Medical Center in the Netherlands, and I will present the results of the HYPE trial. This was a randomized clinical trial where we assessed the ability of a machine-derived early warning system to actually reduce hypertension during surgery. And as of today, published in JAMA. As a research group, we received funding from Edwards. The problem, intraoperative hypertension, it occurs frequently. 87% of patients have at least one hypertensive event during surgery. So why is this relevant? This is relevant because it's associated with postoperative outcomes. This has been shown in both cohort studies and also in one RCT published by Fuchet. And if you summarize those studies, you see that it's associated with cardiac outcomes, such as myocardial injury and myocardial infarction, with renal outcomes, such as ACI, and even with mortality. So therefore, the perioperative consensus statement of 2019 concludes we should try to maintain a MAP above the 60/70 threshold during surgery. And they also state that injury is a function of both the time spent in hypertension, but as well the depth, so the severity of hypertension. And current treatment of hypertension is reactive. Before we conducted the RCT, we did a short prospective observational study, and we saw that the average time from onset of hypertension till first treatment is 1 minute and 30 seconds. So actually that adds up. A potential solution would be to change this treatment from reactive to proactive. However, we as doctors are not always able to predict hypertension in a timely manner. But luckily, a machine learning algorithm is able to do so. And the machine learning algorithm we used in this study is solely based on the arterial waveform. It's developed by a company with input from intensivists and anesthesiologists. And it provides you with a value ranging from 0 to 100. So, for example, 85 means there's an 85% chance of hypertension to occur in the following minutes. This algorithm has been internally and externally validated, showing good results 5 minutes prior to hypertension. But as we all know, prediction is not the same as prevention. In order to actually reduce hypertension, the prediction needs to be followed by a correct and timely intervention. So therefore, we performed the HYPE trial, an RCT, where we wanted to see if it actually reduces hypertension measured at both the time and the depth. For this study, all adult patients planned to undergo elective non-cardiac surgery requiring general anesthesia and with an indication for an arterial line were eligible. And we excluded patients in which the treating doctor wanted to maintain a different MAP, so a MAP higher or lower than 65. And it was also not allowed to use a goal-directed fluid tip protocol or any other protocol. And the other exclusion criteria are based on the early warning system. It's not validated in those patient populations. So what did we do? In the intervention group, we connected the study monitor with the early warning system, and we provided the treating doctor with a diagnostic guide and treatment flowchart created by the study team to enable timely diagnosis of the underlying cause of the impending hypertension. And in the control group, we had standard care, and we connected the study monitor, but we blinded the early warning system. And this is a diagnostic guidance and treatment flowchart. So in this study, we asked the anesthesiologist to act when the chance was higher than 85. And then based on hemodynamic variables visible on the study screen, such as stroke volume variation and systemic vascular resistance, the treating doctor was able to diagnose the underlying cause of the impending hypertension. And important to note, the treating doctor was free to choose the dosage of the drug he or she wanted to administer. Our primary outcome was the time-weighted average in hypertension. So, as I mentioned before, this is a combined endpoint. You take the time in hypertension and the depth of hypertension, and you divide it by the total study time to be able to compare patients. And one of the potential negative effects we thought of using such an algorithm could be overtreatment. So therefore, as secondary endpoints, we assessed hypertension and the dose of medication used. We randomized 68 patients, and 8 of those patients had to be excluded after randomization but before surgery because the treating doctor wanted to maintain a different MAP threshold, or because the surgery was cancelled, or in one case because of technical failure of the device. So we ended up with 31 patients in the intervention group and 29 in the control group. So as you can see, the median age of our population was 64, and the majority of patients were gastrointestinal surgery. And I want to do the exciting part, I think. What we saw is that the time-weighted average in hypertension was significantly lower in the intervention group. But as time-weighted average is a relatively new endpoint and a little bit hard to grasp, we also noted the total time and other hypertension endpoints. And what we saw is that the median time spent in hypertension in the control group was 33 minutes compared to 8 minutes in the intervention group, which I think is an astounding difference. And actually, all hypertension endpoints were significantly different between the two groups. And then onto hypertension, so the assessment of overtreatments. We saw no difference between the two groups for all hypertension outcomes. And lastly, the dose of medication used. We saw no difference, no significant difference between the two groups in vasopressor use and in fluids used. This study has limitations. First of all, our results are only applicable to this specific patient group, entailing high-risk surgical patients. It was a single-center RCT with a small sample size powered on the primary endpoint, and we used a physiological rather than a purely clinical endpoint. And in this stage, that was necessary, so we chose hypertension. And I think this study is a really important stepping stone, but future studies should aim to assess whether this also actually leads to reduction in mortality and in morbidity, and whether it's cost effective. So to conclude, in this trial, we assessed whether we could use a machine learning derived early warning system to reduce hypertension, and we were able to do so without inducing overtreatment assessed by hypertension or dose of medication used. And future trials should assess whether this also leads to a decrease in complications and is cost effective. I would like to thank the HYPE study team, and I would like to thank you for your attention.
So we have time for a question.
Excellent presentation, phenomenal. We've been trying to do some work with waveform data from the arterial line, and one of the problems that we have is a lot of noise, whipping and clipping and things like that. Was that a problem with the trial, or does the device already have a way to sort of ensure the quality of the waveform so that the output is consistent? And
So do you mean you have problems with developing the algorithm or with using it in clinical care?
The waveform data is not clean in the sense that there's a lot of movement artifact that will affect the quality of the waveform, and hence any data, any models that we build on the waveform has to take into account the quality of that data. Has that been an issue or not necessarily?
No, so for the development of the algorithm, that data was cut out because it's not good to build your algorithm on. And in clinical practice, we sometimes had that issue. So therefore, it's important there's a doctor to ensure the arterial waveform is of good quality.
Okay, thank you.